Audiovisual presentation, non-medical prescribing. Introducing Jane, a 59-year-old female patient. Jane contracted podiatric surgery complaining of excessive post-surgical pain 2 days post-operatively following a first tarsometatarsal joint lapidus arthrodesis. She had been discharged with TTOs of codeine phosphate and paracetamol. Jane had no positive allergic history, and medical history included mild hypertension. The clinical impression at this point was nociceptive pain induced by the preceding surgical stimulus. Clinical assessment revealed difficulty with pain isolated to Jane's surgical site. Further questioning revealed Jane had stopped her codeine due to the feeling of nausea and an episode of vomiting. Clinically, there were no clinical signs of infection, either local or systemic, with no reported post-operative trauma or signs consistent with deep vein thrombosis, such as calf pain or tenderness. Jane's observations were taken and her NEWS 2 score was calculated with no remarkable findings. Although the NEWS 2 score is the most widely used tool to assess and monitor deteriorating patients, it does not incorporate pain, which has been described as the fifth vital sign by Naidu and Pham, which emphasises its significance in the acute presentation. Jane rated the intensity of her pain on a numerical rating scale from 0 to 10, which revealed a result of 8, correlating with moderate discomfort. We utilise the validated numerical rating scale for pain because it's quick and convenient and can be used before and after a variety of interventions to assess efficacy over time. Contrastingly, Edwards et al. Advised that while practical and efficient, the NRS may not be statistically sensitive enough to detect treatment effects, and its unidimensional design limits the characterization of the multidimensional nature of pain. Accordingly, more multidimensional tools such as the Brief Pain Inventory and McGill questionnaire were developed to incorporate additional aspects of pain such as sleep disturbance and psychological effects. Nonetheless, these tools are more limited in the acute setting due to their lengthy application. Jane also had a moderate pain face, which can be used as an indirect measure to gauge pain levels, and the Wong-Baker Faces scale, which is more commonly known in the paediatric population, has been validated for use in adult orthopaedic surgery by Van Jiang. Moon and Aleshi identified that pain and postoperative nausea and vomiting are the most common reasons for hospital admission following ambulatory surgery. Furthermore, the NIAA found that data extracted from 124 UK hospitals and nearly 20,000 patients found an incidence of 20% of patients suffer with severe postoperative pain. In a similar vein, Small and Laycock performed a cross-sectional observational study of over 15,000 UK patients undergoing surgery, revealing 37% suffered with moderate pain during the same timeframe. Shapiran and Shah cite the high incidence of PONV with the use of opioids thought to be caused by stimulation of the medullary chemoreceptor trigger zone. The standard of treatment in those suffering from opiate-induced PDNV is either with appropriate antiemetics or adjuvant medication to decrease opioid requirement and reduce vomiting sensation. The decision was made to withhold Jane's prescribed codeine. She subsequently was prescribed Nefapam 60mg TDS in conjunction with her TTO paracetamol. This is the standard loading dose advised for Nefapam according to the BNF. And is known as a central-acting non-opioid, non-steroidal analgesic that inhibits the synaptic reuptake of serotonin, norepinephrine, and dopamine. Son and Do highlight that in contrast to opioids, Nefapam has a negligible addiction profile with no postoperative sedative or respiratory depression effects. Moreover, unlike NSAIDs, there is no impact on platelet aggregation, which is an important consideration for post-surgical hemostasis and high bleeding risk procedures. Nefapam's pharmacodynamic profile lends itself to post-surgical use as an adjuvant analgesic or alternative to the opioids. It is a potent and rapidly acting analgesic, which in this case was important as the patient's pain was poorly controlled after stopping her codeine. Evans et al. Conducted a systematic review to ascertain the role of Nefapam in postoperative pain management. They found a statistically significant decreased pain intensity at 24 hours and reduced morphine requirement, but an increased risk of tachycardia and sweating in 847 patients. These findings were reaffirmed in a meta-analysis by Martinez, in which he also determined combination therapy of paracetamol with either NSAID or Nefapam was superior to most analgesics in reducing morphine consumption. In orthopaedic surgery specifically, de Monoir found that Nefapam has been shown to decrease morphine requirement and improve pain levels with minor side effects, including nausea and dizziness and sweating, in 15 to 30% of patients. Although Nefapam is indicated and licensed for the relief of acute and chronic pain, including postoperative pain, a Cochrane review in 2009 highlighted insufficient evidence to support single-dose oral Nefapam in the postoperative setting. Interestingly, Nefapam has been omitted from the latest NICE guidelines pertaining to perioperative pain management published in 2020. However, there is a distinct paucity of practice guidelines and literature specifically regarding analgesic recommendations for the opiate intolerant in this population. To this end, local guidelines support its use as a suitable weak opiate alternative. Jane did not have any factors that precluded her from oral administration, nor any factors that could potentially reduce drug absorption from the GI tract. She confirmed no further emesis since stopping her codeine. Nefapam is largely protein-bound and is cognizant of any of the pharmaceuticals the patient may have been taking that could have displaced Nefapam and increased the amount of free drug in the plasma. Furthermore, because the patient was not classed as elderly, there was no requirement for dose reduction to account for the reduced renal/hepatic function and plasma protein concentrations. Non-medical prescribing is affected by statutory law, specifically the Medicines and Misuse of Drugs Acts and the subsequent amendments. These acts are primarily designed to ensure public safety, quality and efficacy while controlling the routes of access to drugs. Nefapam is classed as a prescription-only medication, which is only available with a prescription supplied by a qualified, authorised prescriber and for the use in the patient named on the prescription. Nefapam itself is licensed for the relief of acute and chronic pain, including postoperative pain. By prescribing a medicine in accordance with its licensing agreement and terms of use, this in effect gives the prescriber a layer of protection, as the marketing authority holder will be liable for any adverse effects the medication may cause. This protective mechanism is not afforded when medications are used off-label. As a healthcare professional from a podiatric background, I'm regulated by the HCPC, which can impose periods of supervised practice, suspension or removal from my professional register for breach of statutory professional law. Furthermore, podiatrists can only prescribe those medications which are relevant to the treatment of disorders affecting the foot and ankle and associated structures, which was appropriate in this case. Duty of care is the basis of healthcare law and occurs in situations where it is reasonably foreseeable that a practitioner might cause harm to patients through their actions or omissions. As an active practitioner and a prospective independent prescriber, I owed Jane a duty of care in this instance and was aware that by breaching my duty of care that this provides the basis of civil legal action under the tort of negligence. It was important to remember that my duty of care extends to all aspects of practice, including obtaining informed consent. The Bolam test supported the notion that a prescriber will be judged against a reasonable body of non-medical prescribers undertaking the same role in the event of a breach of duty. However, the subsequent Montgomery ruling in 2015 redefined the basis of informed consent in a healthcare setting, and accordingly the test of materiality was developed, whereby a reasonable person in the patient position would be likely to attach significance to the risk they should be informed of it. The Healthcare and Associated Professions Order 2014 requires that all regulated health professionals should be covered by professional indemnity insurance, which is provided by membership with the College of Podiatry in my case. Vicarious liability is a consideration where the employer takes legal responsibility for the actions of its staff provides protection for non-medical prescribers. Holding a prescribing qualification does not automatically allow one to prescribe if prescribing is outside the terms and conditions of their employment contract. Accordingly, having one's employment contract amended to reflect their new prescribing duties may be considered a prerequisite to prescribing independently. The HCPC Standards of Conduct, Performance and Ethics set out how registrants should behave and outline what the public should expect from their health professional. The principles provide an ethical foundation for my day-to-day practice and are aligned with the core ethical principles in many ways. In particular, they include respecting confidentiality, promoting and protecting the interests of service users, ensuring valid consent to treatment, and being honest and trustworthy and open when something goes wrong. There are a number of ethical principles which underpin prescribing practice, the most common of which are described by Beauchamp and Childress. There has been a significant move away from medical paternalism towards autonomy and informed consent. As a prospective independent prescriber, it was important to outline the treatment choices available to Jane and ensure patient autonomy. I did this by providing her with sufficient background information about her presenting complaint and then discussed potential treatment options and the anticipated prognosis of the treatment options, including no treatment. Upon recommending a treatment option, I made Jane aware specifically of the side effect profile of Nefapam, including the potential for ongoing nausea in some individuals. I also wanted to ensure she was fully informed and gave her the opportunity to ask any further questions. I was mindful to respect Jane's treatment, even if it wasn't in line with my recommendations. Non-maleficence in the context of prescribing cannot be regarded as an absolute, as all medications have potentially harmful side effects. In terms of my prescribing decision, it was important to fully evaluate Jane's medical and allergic history and incorporate this into my prescribing decision so that a safe, efficacious treatment could be advised. Prescribing in a matter that aims to optimise the good for patients by seeking the most appropriate and effective treatment fulfills the principles of beneficence. In this case, I followed local guidance on the prescription topic underpinned by a contemporaneous, albeit mixed, evidence base. I was also mindful that while beneficence was respected, the patient could still be exposed to detrimental side effects. In terms of justice, Jane was treated equitably. There was no discrimination on the basis of sex, race, religion, age or distribution of resources. The 4 rules also help to underpin ethical decision-making, including veracity and fidelity, and privacy and confidentiality, which were respected at all times. Plant and Pitt defined the 5 spheres of accountability, including one's profession, patient, society, employer, and individual themselves. All NMPs were required to work within the boundaries of their own standards of conduct with the intention of providing high-quality standards of care, safeguarding the public, and promoting professional credibility. In this regard, professional codes of practice provide practitioners with a regulatory framework for prescribing Podiatric surgery is regulated by the HCPC, which has its own standards of conduct, performance and ethics, and more recently revised standards for podiatrists practicing podiatric surgery. Furthermore, to support all prescribers to prescribe effectively, the Royal Pharmaceutical Society developed the Single Prescribing Competency Framework, which has been adopted by the HCPC to define the standards for those with prescribing responsibilities. There is significant overlap with the standards of proficiency, best practice in prescribing produced by the College of Podiatry and prescribing competency framework adopted by the HCPC. Incorporating the HCPC podiatric standards, a thorough, sensitive and relevant detailed history was taken, including allergic history as per the RPS framework, while factoring in over-the-counter medicines complementary therapies in accordance with the COP best practice guidelines. This could be evidenced prior to the prescribing decision was documented accordingly. Furthermore, appropriate clinical assessments carried out in the post-operative context, systematically excluding any ulterior causes of the patient's pain, such as infection, DVT or trauma. Standard 12 for the podiatric surgery proficiency standards include routine post-operative monitoring and evaluation, which was supported with assessment of the NEWS2 scoring system and pain scales. Although no clinical investigations were necessary in this instance, the working diagnosis was formulated by a process of elimination after systematically considering the alternatives as per standards 1.4 to 1.6 of the RPS framework. In accordance with standard 1.7 of the RPS framework, reviewing adherence to the patient currently prescribed medications was arguably the most important facet of the case, which revealed intentional non-compliance due to the effects of nausea and vomiting attributed to her codeine prescription. After establishing a working diagnosis, both non-pharmacologic and pharmacologic options were discussed, including no treatment, deprescribing her codeine in isolation, and or prescribing an alternative analgesic or adding an antiemetic as per standard 2 of the RPS framework. As only a singular episode of emesis had occurred, with no further episodes since codeine cessation, the decision to deprescribe the codeine was taken. This decision was in line with standard 1.9 of the standards of proficiency of podiatric surgery, which entails recognising and responding to complications arising from drug administration. After reviewing Jane's comorbidities and medical social allergic history and determining no contraindications, nefapam was offered as an opioid alternative. The risks and benefits of the patient adopting this approach were discussed at length, including the potential development of chronic pain syndrome with no treatment and the potential for further nausea with treatment. This forms standard 2.3 to 2.5 of the RPS framework and College of Podiatry best practice guidelines. Given Jane's episode of emesis, the route of oral administration was deemed appropriate only after she had confirmed no further episodes of sickness and that she was able to eat and drink as per standard 2.6. A two-way drug interaction check was performed using the BNF app, which was unremarkable, consistent with standards 2.7 and 8. In accordance with RPS Standard 3, a relationship with the patient was developed, ensuring the patient was sufficiently informed without duress and deemed as having capacity, respecting the basis of informed consent. The consultation was approached holistically, ensuring that the patient's concerns and opinions were respected at all times. After individual treatment options were discussed, a shared decision was reached between myself and Jane to deprescribe her codeine and prescribe nefapam 30 to 60 mg TDS as an alternative. In line with standard 4, this prescription followed local protocol for those suffering with opiate intolerance, and James was fully informed of the potential for adverse effects, which ranged from persisting nausea to tachycardia. She was informed on how to recognise and manage any of the side effects, including medication cessation for the latter. The prescription was also satisfy the podiatric surgery proficiency standard 13, which implies the ability to recognise common post-operative complications and manage them accordingly. Furthermore, the nefapam dosage and quantities to be supplied with checked in the BNF app with full documentation of the prescribing decision in the patient notes. As per RPS Standards 5 and 6, Jane was given a clear written and verbal instruction about her prescription and advised to refer to the summary of product characteristics for further information. She was also advised regarding departmental contact details to use in the event of any concerns regarding her prescription. A follow-up phone call was arranged the following day, and Jane was reviewed 1 week post-operatively as per standard, but with the caveat that she may contact via telephone for it at any point. As evidence of prescribing safely, RPS 7, the decision to prescribe in this instance was performed within the limits of my professional scope and knowledge base. In terms of prescribing professionally, as previously mentioned, I am aware of my professional and legal obligations with respect to prescribing and accountability. I was aware that this medication followed local pathways but was neither out my scope of practice nor breaching any legal framework whilst being prescribed in the best interest of the patient. Optimising perioperative pain is regarded as a national priority and reflects one of the key areas highlighted in the most recent Perioperative Quality Improvement Programme in 2019 endorsed by NICE. Pain is associated with a cascade of physiological events, and inadequate pain control may result in the need for increased rescue interventions, myocardial ischemia, and delayed post-operative recovery. A systematic review and meta-analysis based on 33 studies and over 50,000 patients identified significant associations with younger age, female gender, smoking history, and history of depressive stroke anxiety symptoms. Accordingly, being able cognizant of these associations preoperatively may influence analgesic management and therefore post-operative outcomes. As an HCPC registrant, I have both a statutory and professional obligation to actively engage with CPD activities in order to remain registered and provide best care. Moreover, my employer requires an annual competency declaration for prescribing. With this in mind, I have a number of opportunities to meet my obligations. First and foremost, familiarising myself with local NMP prescribing policy and relevant NICE guidelines, engaging with e-learning facilities and e-alert systems from the MHRA, and attending my local NMP forum to discuss key issues related to non-medical prescribing in the event of revalidation. And here are finally a list of my references.